Imagine you're lying in a hospital bed. The doctor lightly brushes a feather against your leg, and you feel absolutely nothing.
Right, complete numbness.
But at the exact same moment, you are experiencing this severe burning pain in that very same leg.
Which sounds, biologically impossible.
Totally. But in the world of spinal cord injuries, it is an everyday reality.
Yeah, that paradox is actually the perfect entry point for us. The reality of what happens when the signals between the brain and the body are cut is so much more complex than what people picture when they hear the word paralyzed.
I mean, the entire diagnostic landscape is just incredibly murky.
It really is.
Which is exactly our mission for this deep dive. Today we are unpacking the fascinating, highly misunderstood pathophysiology of spinal cord injury, or SCI.
And we've got a great stack of sources today spanning medical history, clinical definitions, and some truly mind-bending anatomical insights.
We do. So, okay, let's unpack this.
Yeah.
Because to start, we really have to throw out the old textbooks. SCI is no longer defined just as a story about paralysis and numbness.
No, not at all. Contemporary medicine defines it as this massive multi-system disruption.
Right.
We are talking about the loss of cardiovascular regulation, temperature control, bladder and bowel function, sexual function, and, well, the rewiring of chronic pain circuitry.
And these are not just side effects, right? Like, they are core components of the trauma itself.
Exactly. A high cervical injury in the neck is now understood as a cardiovascular and respiratory disease just as much as a loss of motor control.
Because the sympathetic nervous system, the automatic wiring that controls our fight-or-flight responses, like heart rate and blood pressure, that's running right through that exact same cord.
Yeah, it's all housed in the same structure. But, you really can't understand why doctors today view the spine as this complex, salvageable system without understanding the history.
Oh, for sure. How recently this injury was considered an absolute, undeniable death sentence.
Right. If we look at the ancient Egyptian Edwin Smith papyrus, this is dating back to roughly 1600 BCE. The text bluntly refers to spinal injuries with paralysis as an ailment not to be treated.
Wow. Not to be treated.
Yeah. It was a remarkable, if grim, acknowledgement that humanity just had absolutely zero tools to fix it.
And that grim reality held true for thousands of years. I mean, even entering World War II, a severed spine was basically a death sentence.
Pretty much, yeah. The shift to modern care actually didn't begin until 1944.
Right, with Sir Ludwig Guttmann.
Yes. He was a German-Jewish neurologist who fled Nazi Germany, and he was asked by the British government to open a specialist spinal injuries unit at Stoke Mandeville Hospital.
And the situation he walked into there was just horrific. Most soldiers with these injuries were dying within weeks.
But Guttmann realized they weren't dying from the severed spinal cord itself.
Right.
They were dying from entirely preventable secondary issues.
Wow.
Specifically infected pressure sores from lying motionless in bed and urinary sepsis.
So the injury wasn't killing them, the hospital bed was.
Exactly. So Guttmann mandated this incredibly aggressive nursing care. He forced the staff to turn patients every 2 hours to prevent those pressure ulcers.
And he introduced meticulous bladder management.
Right. Yeah. He completely swapped strict bed rest for active rehabilitation. He eventually introduced wheelchair sports to build upper body strength.
Which is amazing because that radical idea actually birthed the modern Paralympic Games.
It did. And because of Guttmann's work, SCI went from a near-certain death sentence to a survivable condition in the span of really just a single generation.
Which is an incredible leap. But because patients were finally surviving the initial trauma, the medical field suddenly had to figure out how to measure and categorize the long-term reality of their injuries.
Right. And that necessity brings us to the Asia Impairment Scale. That's the standard tool used today by the American Spinal Injury Association.
It grades injuries A through E, right? Where A is designated as a complete injury.
Yes, grade A is complete.
Wait, hold on. I need to push back here.
Yeah.
If an ASIA grade A is literally called a complete injury, you're telling me the cord isn't actually completely severed.
I know, it sounds totally contradictory.
Isn't that incredibly misleading for a patient waking up in a hospital bed trying to understand their prognosis?
It is deeply confusing for patients. But the clinical definition of a complete injury has never actually been strictly anatomical.
Okay, so what does it actually mean then?
It simply means there is no detectable voluntary motor function or conscious sensation in the lowest sacral segments on a physical exam.
So that's purely a statement about what a neurologist can observe at your bedside with, like, a pinprick in a strength test.
Exactly. It is absolutely not a microscopic guarantee that the cord is physically cut in half.
Okay, so a doctor says complete, But biologically, there might still be wires crossing the gaps.
Yes. In the 1990s and 2010s, researchers like Milan Dimitrijevic and Susan Harkema used advanced electromyography to prove this.
What did they find?
They showed that a meaningful fraction of clinically complete injuries actually retain fine subthreshold neural connections across the lesion.
Wow. And this is a category now sometimes called a discomplete injury, right?
Right. The signal's present, it's just too weak for the bedside pinprick test to catch.
Here's where it gets really interesting. Because if there are these subthreshold connections surviving, we need to picture the physical anatomy of the spinal cord itself.
Which most people get wrong.
Yeah, I think most people picture it as a generic extension cord. You know, chop it and the power goes out.
But it's not like that at all. It's more like a highly organized fiber optic cable with distinct segregated tracks carrying very specific signals.
So strip away the medical jargon, and SCI is fundamentally a wiring problem.
Exactly. And the architecture of that cable is intensely specific. Take the corticospinal tract, for example, which runs down the back and sides of the cord.
Right.
That wire specifically carries the voluntary motor commands from your brain down to your muscles.
So if you're listening to this right now, run your hand down the back of your neck. The nerve fibers controlling your hands are actually bundled right in the center of that cord you're touching.
Yep. While the fibers destined for your legs are wrapped around the outer edges of the cord.
That concept is known as semitopic organization, right?
Yes. And running alongside those motor wires, you have the dorsal columns at the very back of the cord.
And what do those do?
Those carry fine touch, vibration, and proprioception, which is your sense of where your body is in space upward to the brain.
Okay, and then near the front of the cord, you have the spinothalamic tract, which carries pain and temperature sensations.
Right. And there is a major geographic quirk to this wiring that is crucial to understand.
The crossing over, right. The motor and touch wires stay on the same side of the body until they reach the brainstem.
Yes, but the pain and temperature wire crosses over to the opposite side of the spinal cord almost immediately after entering it.
Which is wild, and that quirk explains some bizarre clinical outcomes we will look at shortly.
Definitely. But first, we need to understand how this intricate fiber optic cable actually takes damage, because it is never just a single event.
Right, there are two distinct waves to a spinal cord injury. The primary injury is the initial mechanical trauma, like a burst fracture from a car crash, or a contusion from a bad fall.
And that happens in milliseconds. Practically speaking, it is completely unfixable.
The real tragedy is the second wave. That initial impact triggers a secondary injury cascade that unfolds over hours to days.
Yeah, local blood vessels get crushed and swell, cutting off oxygen to healthy tissue, a process called ischemia.
And then the injured neurons start dumping massive amounts of a neurotransmitter called glutamate.
Right, exactly. While normal amounts help cells communicate, these massive dumps overexcite and literally kill neighboring neurons that survive the initial impact. We call this excitotoxicity.
But plus, free radicals and inflammatory immune cells just pour into the area, tearing apart healthy cell membranes.
It's basically a biochemical fire spreading from the initial spark.
And all this swelling is happening inside the spinal canal, which is made of solid bone. It has absolutely zero give.
None. So the pressure builds up, further choking off blood flow.
That unyielding bone is why the area of permanently dead tissue ends up being far larger than the area damaged by the initial trauma.
Exactly. And it also explains why the first 24 to 72 hours after an injury are the primary focus of experimental drug trials today.
Because you cannot undo the car crash, but if you can extinguish that biochemical fire, you might save crucial millimeters of salvageable tissue.
Right. What's fascinating here is when we take these first principles, the distinct wiring tracks and that expanding secondary cascade, and look at how they manifest in the real world.
Yeah, let's look at some real examples. Think of Christopher Reeve, the actor famous for playing Superman.
Right, in 1995.
He had a horse riding accident that resulted in a fractured dislocation at C1-C2. That is the absolute top of the spinal cord, just below the brainstem.
Because the C1-C2 level controls the nerve supply to the diaphragm, Reeve required a mechanical ventilator to breathe for the rest of his life.
A few centimeters higher, the injury would have hit the brainstem itself, which is just instantly fatal.
But a few centimeters lower, and he likely would have kept independent breathing.
Tragically, he passed away 9 years later from a cardiac arrest triggered by an infective pressure ulcer.
Which just shows that decades after Gutman transformed the standard of care, those secondary complications remain a lethal threat.
They really do.
Yep.
We also see how the specific layout of those tracks creates clinical paradoxes. Consider central cord syndrome.
First described by Richard Schneider in 1954, right?
Yes, exactly. It is the most common incomplete injury pattern today. It typically happens when an older adult with arthritis falls and hyperextends their neck.
The paradox here is that the injury is in the neck, yet the patient ends up with far more weakness in their hands and arms than in their legs.
Which makes no sense initially. Why on earth would a neck injury spare the legs?
Well, this goes back to the physical bundling of the fibers we discussed earlier. The fibers for the arms are packed into the center of the cord.
Ah, right. And the leg fibers are on the outer perimeter.
Exactly. So a hyperextension injury squeezes and damages the center of that cable the hardest, taking out the arms while leaving the outer leg fibers largely intact.
So the cable is literally bundled by body part.
It is. Another mind-bending example is Brown-Séquard syndrome, discovered around 1850.
From observing half-core damage. Right, like someone taking a knife wound to just one side of the spine.
Yeah. It produces a really puzzling set of symptoms. If the right side of the spinal cord is severed, the patient loses motor control and fine touch on the right side of their body.
Okay, that tracks.
However, they lose pain and temperature sensation on their left side.
Which sounds completely impossible until you remember the geographic quirk of the wiring. The motor and touch wires stay on the same side until the brain.
Right.
But the pain wire crosses the street immediately. So pain signals from the left side of the body crossed over to the right side of the spinal cord and then hit the roadblock on the right.
Exactly. It is pure anatomy dictating function. But because this anatomy is so delicate and that secondary fire is so destructive, the desperation for a medical fix has historically led to incredibly controversial decisions.
Yeah, let's talk about that. Let's unpack the National Acute Spinal Cord Injuries studies, or the NASCEs trials from the 1990s.
Oh, this is a big one.
The idea was to pump patients with massive doses of a steroid called methylprednisolone within 8 hours of injury. The goal was to reduce inflammation and stop the secondary cascade.
Right, and initial publications claimed a modest motor improvement. The desperation in the medical community for any kind of treatment was so high that, almost overnight, high-dose methylprednisolone became the global standard of care.
Literally any emergency room doctor would administer it.
But the fatal flaw was that the improvement data came from a subgroup analysis that many statisticians viewed as a massive post hoc reach.
And the real-world results ended up being brutal.
Yeah. By the 2000s and 2010s, follow-up analyses revealed this massive steroid dose carried a severe increased risk of pneumonia, sepsis, and gastrointestinal bleeding.
The supposed benefits just weren't replicating in patients. Major medical societies eventually had to walk the recommendation back.
It stands as one of the field's most sobering cautionary tales. It really shows the dangers of a well-intentioned treatment spreading faster than the rigorous evidence needed to support it.
And we see a similar tension in the broader philosophical debate, right? The debate of funding a cure versus funding care.
This is a huge divide. You have hundreds of millions of dollars flowing into the search for biological cures.
A prime example is Geron Corporation's 2011 embryonic stem cell trial. Because embryonic stem cells are pluripotent, meaning they can theoretically become any type of tissue, this trial generated massive media hype.
Oh, massive. Patients thought a science fiction-level biological cure was finally here.
The hope was that stem cells could replace dead tissue and rebuild the cable.
But the trial was abruptly shut down early, and not because it was scientifically proven to fail, but for business and financial reasons.
Which was just a devastating psychological blow to the patient community.
It really was.
And it fuels the argument from disability advocates who point out we routinely underfund the unglamorous things that actually keep people alive and participating in society right now.
Things like accessible housing, better wheelchair engineering, and daily bladder management.
Right. The pursuit of tomorrow's miracle often starves the reality of today.
But occasionally, research forces us to completely rethink what a cure even means.
Yes. So what does this all mean when we look at someone like Rob Summers?
Well, in 2011, Rob Summers, who sustained a motor-complete cervical injury, received an epidural electrical stimulator implanted over his lumbar spinal cord well below his injury.
And with that stimulation turned on and intensive physical training, he regained the ability to voluntarily move his legs, stand, and take assisted steps.
Even though his clinical diagnosis stated there was no functional connection between his brain and legs.
Which is incredible. It implies something revolutionary. The physical wiring below the injury is not actually dead.
No, it's not. The spinal circuitry contains central pattern generators. Think of these as miniature brains located in the lower spine that inherently know the rhythmic muscular pattern of how to walk.
Right, they are perfectly intact. They are just starved of the electrical start signal from the brain. I've always thought of it like a car engine. The engine itself is in perfect working condition, but the ignition wire from the steering wheel got snipped.
It's a great way to look at it.
The epidural stimulator is basically hot wiring the car. It applies local electrical voltage to wake up those mini brains in the spine so they can do what they naturally know how to do.
And that raises an important point. It totally redefines the playing field for treatment.
But before we get too far into the future, we need to clear up the minefield of confusing terminology surrounding this condition. Because people frequently mix up spinal shock and neurogenic shock.
Oh, all the time. They sound like the exact same thing, but biologically they are completely different beasts.
Let's break it down.
Okay, so spinal shock is a temporary phase immediately after the trauma where all reflexes below the injury level completely shut down. The cord essentially goes silent.
And doctors monitor for the end of spinal shock by checking for the return of the bulbocavernosus reflex, right?
Yes. That is a spinal reflex testing the absolute lowest sacral nerves. Once that reflex returns, doctors know the shock phase has passed.
So spinal shock is a temporary blackout of reflexes. Neurogenic shock, on the other hand, is a severe cardiovascular crisis.
Right. If the injury is high enough, usually above the middle of the back at the T6 vertebrae, the body loses that sympathetic nervous system tone we talked about earlier.
Blood pressure bottoms out dangerously low, and the heart rate slows down.
And speaking of cardiovascular crises above T6, we must explain autonomic dysreflexia.
This is a terrifying, life-threatening complication. The mechanism behind this is just wild.
It really is.
It's like a patient has a full bladder or even just a tight shoe. That irritation sends a distress signal up the spine.
But it hits the roadblock of the injury.
Right, so it bounces back out into the sympathetic nervous system, causing blood vessels below the injury to massively constrict.
And this massive constriction spikes the patient's blood pressure to stroke-level heights.
The brain detects this dangerous high blood pressure and tries to send a slow down, dilate the vessels signal.
But that signal cannot get past the roadblock either.
So the body is sounding a blaring alarm, the blood pressure keeps rising, and the brain cannot reach the off switch.
It's incredibly dangerous. We also need to talk about the glial scar, which is the ultimate biological double-edged sword.
Right, because to stop that secondary biochemical fire from spreading, the body forms a dense scar to seal off the injury site.
It saves the healthy tissue, but it physically and chemically blocks any surviving axons from ever regrowing through it.
So it ensures survival at the cost of regeneration.
Exactly. Let's revisit the misconception from our opening hook, too. People assume if you have a complete injury and can't feel a feather brushing your leg, you definitely can't feel pain there either.
But because touch and pain travel on completely separate anatomical tracks, the injury can wipe out the touch pathway, leaving the limb totally numb to external stimuli. Meanwhile, the pain pathway gets damaged in a way that leaves it constantly misfiring, resulting in severe, burning neuropathic pain in a leg you can't otherwise feel.
Understanding that anatomical complexity also debunks the myth that an injury higher up the spine is always universally worse.
Because the level of the injury matters, but the completeness of the injury matters just as much.
Exactly. A complete injury in the mid-back might leave a person with far less overall function and independence than an incomplete injury in the neck where crucial arm and hand movement is spared.
So what does this all mean for you listening to this deep dive today?
Well, spinal cord injury is not some rare, isolated medical curiosity.
Hundreds of thousands of people live with it in the U.S. alone, largely from everyday events like car crashes and falls.
And it silently dictates the public infrastructure you interact with every single day.
Exactly. Curb cuts on sidewalks, accessible transit systems, the Americans with Disabilities Act. All of this was built around the realities of SCI and the relentless push of disability advocacy.
And scientifically, this injury sits at the very frontier of modern neuroscience. The work happening with epidural stimulation, biomaterial scaffolds, and brain-computer interfaces is rapidly moving from laboratory theory into active clinical trials.
Which leaves me with a final thought for you to mull over. We saw with Rob Summers that the neural engine below the injury often remains perfectly intact, just asleep and waiting for a spark.
Right.
If the physical wiring is too scarred to regrow, Will the future of treatment look less like trying to biologically stitch a severed cable back together?
That's the big debate.
And instead, will it look more like using brain-computer interfaces to digitally Bluetooth the brain's commands, bypassing this murky diagnostic landscape entirely and beaming the signal directly to the waiting spinal cord below?
That is the billion-dollar question for the next era of neuroscience.
And maybe that's how we finally get the picture to become clear again.